let's say we are in the emergency department and we are, let's say at the end of your exam, you've picked up a left vestibular hypofunction, which is most likely from a neuritis, which is a viral process of the vestibular portion of the cranial nerve. So that left inner ear is down out, it's not working out. They come in with acute vestibular syndrome symptoms, which are dizziness, and it's usually hours of dizziness, gait instability, nausea. Right, those are like your top three ones. All right, so it has to be kind of prolonged dizziness. Oh, and the fourth big thing with acute vestibular syndrome is nystagmus. Okay, so if you have somebody with a left vestibular neuritis, observation-wise, chances are they're going to have a difficult time opening their eyes. They're going to be possibly having a head tilt towards that side because they're not getting information, or maybe even away from that side. There's an asymmetry of information, so they might be tilting their head one way or another. They don't quite know where center is. Chances are they are in the dark, they're miserable, there's a puke bag right on their chest ready to go. Okay, so that's what you're going to usually see with these patients. As far as cervical active range of motion, they do not like moving. It doesn't mean they are going to not move, but they are not going to like it, and you have to coach them through, because why do we need to see cervical range of motion in a vestibular patient? Yeah, you need to know if you have the range of motion available to perform the testing. So for rapid head thrust testing or head impulse testing, all you really need is 20-30 degrees, not that much motion. But for Dix Hall Pike, you need 45 degrees of rotation. And for roll tests, you really should be trying to get over to 90. So you can use the trunk a lot, but we need to know what range of motion do you have available so I know what testing that I have, and you're also trying to see what their symptom response is to cervical active range of motion. Okay. Now, spontaneous nystagmus in a left vestibular neuritis patient. You say, look at my finger right here, you're about 3 feet away, you're not too close, you're not out here, you're giving them one discrete point, not your entire arm, just the tip of your pen or finger. Look right at my finger here. What do you expect the eyes to do in a left neuritis patient? Which way is the fast phase of the nystagmus? What's the strongest side?
Right side.
Right side. So you see right beating nystagmus. And we call that center gaze. So when we talk about the points of gaze, like the language, trying to make it just easy for you guys. In center gaze, you'll see right beating nystagmus. How about if you bring the eyes to the right? So right gaze above nystagmus position. What would you expect to see?
Increase in the beating.
More intense. More intense right beating. How about in the left gaze evoked position? Still going to the right, but due to Alexander's law and the line of, literally the line of pull of the muscles, it's further away, so it's going to be a slower right beating nystagmus. Or you might see none when you take them over to the left side, because you're so far away, and if it's not strong enough of an asymmetry, you might not see anything in the left gaze position. Okay, now if you take her to the right and you see right beating, you take her to the left gaze position and you see left beating, what is that indicating?
Central.
Central. It's a bad sign. Remember to not take them to end range nystagmus. The end range ocular position. You want to take them roughly halfway over their range of motion. You want to still be able to see a little bit of the whites of the cornea on both sides. Otherwise you might get 2 or 3 beats, almost like clonus at the end. You can just ignore that, okay? You don't want to take them to end range, it could be confusing. Smooth pursuit testing. So, April's looking at my finger in center gaze. This is the test for spontaneous nystagmus. Now I'm going to take her over to the right. Pause here for about 5 seconds or so. Each position is about a 5-second pause. Really kind of hang out and watch, make sure you're not missing anything. And then over here. So it's not this, you're not doing smooth pursuit testing, like follow my finger during gaze evoke testing. It's simply 1, 2, 3 positions. Move your finger, have them hold. Move your finger, have them hold. Now with smooth pursuit testing, that's where you go, okay, now don't move your nose at all, right? The head doesn't move at all. Follow my finger all the way to the end range. This is an end range ocular range of motion test. You're going into the H pattern, all the way up, all the way down. Now I don't see any of the cornea on both sides. I'm checking all those planes of motion, big letter H. Do they have underlying full ocular range of motion to even express underlying nystagmus? Do they have any palsies? Their eyes are not moving in one direction. You have to understand their baseline ocular motion. You guys remember what smooth pursuits, if it's a positive test and it's alarming, you remember what the language is behind that? Like what would you see in an abnormal smooth pursuit test?
Conjugate or saccadics.
So, yeah, so disconjugate is one thing you're really looking out for. That's when one eye is slow to adduct. The eyes basically are not flowing together. You want them to be moving the same rate all over the place. One eye is adducting, the other adducting at the same exact rate. If one is slow, that's disconjugate motion. That's a very strong central sign. Now there's another observation you're looking for.
Saccadic intrusions.
Saccadic intrusions. So when we get to the part where we're testing you on this, almost everybody screws this part up. And it's right there in red on your form, right? It's right there. Saccadic intrusions, that's the language we're using. If the eyes are slipping off of your finger, that's the target. Their eyes are slipping off the target. Saccadic intrusions. And that's confusing because there's also a specific test for saccades. But that's the classic vestibular language. So it's a lot easier if you keep it straight in your head what the language is. The eyes will slip off, slip off, slip off, slip off of your finger as you go in the H pattern. So keep in mind that the head is not moving when you're testing smooth pursuits. The nose is perfectly still. The vestibular system is not being activated because the head is stationary. So it's not a vestibular test, it's a brain test. This is a brain-related test. So if you see those abnormal saccadic intrusions, it could potentially be a central sign. But if the person is over 65, they're elderly, that might be normal. And if that's your only finding, that you're not gonna just ask for a brain MRI and recommend the patient's admitted and crumble into a puddle underneath yourself. That's a fairly normal finding in the elderly population. So I was trying like have you memorize it by like Medicare patients might have positive saccadic intrusions, and that's okay. If that's your only finding, no big deal. Now if it fits a bigger pattern of central, then it becomes a more important finding.
Same with the disconjugate, would that be?
No.
No.
No
That's
elderly
not
person
normal.
should have this conjugate motion.
What about if they have any optometrist, like eye-related, vision-related issue?
So do you mean like a lazy eye? They should be able to control it when they're
Same way.
pursuing though. It's more like when they're looking at you, one eye starts to drift out.
Right.
So they should be able to kind of keep it all together during smooth pursuit testing. Even if it's sitting out a little bit, it should move with the other one smoothly. But if you see,
What's the difference?
Hmm?
What's the difference?
the difference is the slip, for disconjugate,
Yeah.
because disconjugate, they're not moving at the same rate.
There.
Even if it's a lazy eye and one is
You can
sitting out.
start it
further.
in a different position as long as the rate's similar.
Yeah.
Yeah.
I was too focused on position. It's more about rate.
And then the saccadic intrusions is constantly slipping off your finger.
Yeah,
Okay.
slips off your finger. Now, if they have saccadic intrusions and they're in their 50s, that's a little more alarming. And now I'm gonna expand my differential and make sure I do more of a full central neural exam. Could be the early signs of a cerebellar problem, alcohol toxicity, early Parkinson's, especially vertical, they have a hard time in smooth pursuit, Parkinson's, atypical Parkinson's especially. So now let's talk about saccades, the saccade testing. You might hear it called saccades. The optometry field likes to call it saccades. So that test is, again, you're about 3 feet away, and I want you to, this is kind of a, I'm gonna make it sound easy, but this is actually a hard test to coach the patient on. I want you to jump your eyes back and forth between my 2 fingertips as quickly as you can. So you, right to left, okay? But that's the language I use just to start with and see if they get it. I just want you to jump your eyes back and forth between my 2 fingertips as quickly as you can. Ready? Go. 10, 9, 8, 7, 6, 5, 4, 3, 2, 1. So he's going super fast. So you're looking at accuracy. Are they boomeranging out and back, which is a cerebellar sign. Picture finger nose testing in the cerebellar atrophy patient. They're all over the place. The eyes do the same thing in saccade testing if there's a cerebellar problem. That's called hypermetric saccade. So this is going to be on your practical also is the terminology. And again, this is all just to make it easier for you so you're not sitting there at the end of a long day at 5:30 trying to figure out how you want to say this in your documentation. If they overshoot, it's called hypermetric saccades. If they undershoot, it's called hypometric.
What if it's just slower speed?
It's not supposed to be,
Yeah.
and all the stuff you read about saccades, and no matter what age you are, you're supposed to have fast saccades, but the testing part of it is definitely slower in patients who are a little older, or patients who have some cognitive issues, patients who are on drugs. I see it all the time. So what I write is slow, accurate, or fast, accurate. Now, it doesn't mean a lot to you in the emergency department if their saccades are slow, but for me, as somebody who treats concussion down the road, let's say, or even a vestibular problem, the ocular and vestibular systems are on the same circuit board. So if I'm testing somebody's saccades and they're like, oh God, that made me dizzy, that recreated my dizziness, either again from a concussion most likely, or even some vestibular problems will have some dizziness with saccade testing, or saccadic motions in their real life also, then I give them saccade exercises. So down in outpatient, I kind of really target the saccades. So I like to see that as early as possible. If that's their baseline and it doesn't give them symptoms, I'm not gonna have to rehab it. If it does give them symptoms, and it fits a picture, then I'm gonna give them saccade exercises, which we don't really cover in this portion, because again, that's a little bit more advanced, it's a little down the road, but we're trying to just get the main stuff down for acute dizziness right now. So once again, saccades is not a vestibular test, it's a brain-related test, because there's no head movement. As soon as you start moving the head over about 20 degrees, then the vestibular system starts to kick in. At first, the first few degrees are more like cervical ocular reflex kicking in. This is not vestibular yet. You start moving about here, then the vestibular system starts giving you information about where your head and body are in space. So saccade testing is strictly brain-related testing. Smooth pursuit, strictly brain-related testing. I also should just mention saccade testing. So we talked about hypermetric being a valuable test to pick up cerebellar problems. Hypometric, where they kind of leapfrog over, they bounce over, and they fall short initially. You see that a lot in concussion. So if you see somebody in the emergency department who fell off a ladder and they hit their head, that might be an early sign of concussion. Just document it, keep it in mind, and I look at all your notes down the road in outpatient also, and it really helps me. So what would you expect in this left vestibular neuritis patient? What would you expect smooth pursuits and saccades to be? Disconjugate, saccadic intrusions, hypermetric, hypometric, or normal?
Normal.
Normal. It's a brain test.
Agreed.
It's not a brain problem, right? Unless again, they're elderly and their smooth pursuits
I was
are
gonna ask
have
how old.
saccadic
What
intrusions.
is-
Yeah. Okay, so skew deviation, cover the eye, uncover. We can do, well, I'll probably just keep it simple for you guys. We'll just do cover, uncover, just alternate cover, uncover, and leave it there for a few seconds. Maybe 2 or 3 seconds. Cover, uncover, cover, uncover, Make sure they can't see anything around their eyeballs. You can do it to yourself right now and just see if you can fixate on anything. If they can fixate on something outside the perimeter of your hand, they might be able to suppress it. They might be able to actually use their brain to compensate. So you wanna make sure you're really blocking their view around their eye. And you're looking for vertical refixation, like Oscar found and maybe found in that patient in the hospital, okay? If you cover one eye and the other guy goes out horizontally and back, now we're talking probably about a strabismus or lazy eye or some sort of underlying ocular problem. Don't worry about horizontal refixation, just the vertical is what you're looking for. So in a skew deviation test for a vestibular neuritis patient, if this is a left vestibular neuritis, what would skew deviation be? How would you document it? What would you expect? Positive or negative?
Positive or negative depending vertical fixation. That's what I know.
So what is vertical fixation a sign of? Central. So this is not a central patient, right? This is a peripheral vestibular benign problem. So you're hoping it's negative. That's what you would expect to see in a left neuritis patient. Good. Okay. Rapid head thrust or head impulse test. They're synonymous.
Sorry, real
Yeah.
quick, so it would be for, it could be both sides or one, or is it usually both if
For-
they're for positive?
In a central patient,
Yeah.
all your job is to detect
Positive, okay.
if one eye goes up or down.
Oh, okay.
The other eye goes up or down, you don't need to call the eye, you don't need to call
Oh,
down
so
or
it's
up.
positive.
You just
Okay.
say positive or negative.
Okay.
The neurologist will go in and give much more detailed information. Maybe not our neurologist,
Shots
You hope
fired.
so.
but so bad, you guys, this is not a good scene in our neurology department right now.
Oh.
Okay, now, here's the big one. The crown jewel of a classic vestibular neuritis, the rapid head thrust or the head impulse exam. This is part of your HINTS exam. So, in a left vestibular neuritis patient, you take their head and you thrust their head 30 degrees to the right. What would you expect it to be, positive or negative?
Negative.
Correct. The right side's fine, even though their nystagmus is beating to the right. You take their head to the left, which is testing the left vestibular ocular reflex, because you're going towards that side. What would you expect, positive or negative?
Positive.
Positive.
Good. Left neuritis patient, positive head impulse test on the left, right beating nystagmus. You will forget this. You know, it sounds easy right now.
But now that you've said that we're gonna forget it, we're actually going to harder to not forget it.
It's fine. I don't trick. One thing I'm gonna just say, and you can forget if you want. And I might have said this last time, in the hyperacute state of a neuritis patient, you might see nystagmus going towards the bad side in the hyperacute state. Then the next therapist will come in the next day and say, today it was right beating, yesterday it was left beating, what the hell? Walter just came up into my office last week about this patient. And I called her yesterday, so I think it was a week and a half ago, he told me about the case. And I said, yes, Walter, that can absolutely happen. There was a whole section of lectures on this in Sweden about acute dizziness. And we don't quite understand why yet, there's theories, but it happens. So don't freak out, it can switch sides. And it's an ever morphing thing. These are basic rules that are correct the majority of the time. But there is a small percentage, and I don't know what it is, I haven't found any data on it, but it can be towards the same side in the beginning. So don't freak out if you're seeing the same patient 2 days in a row and it switches on you. As long as it's not direction changing nystagmus, as long as it's unilaterally fixed to one side, you feel a lot better about this patient not having a stroke.
Say that again.
Okay.
So if it's beating to the right, it's a left, let's say it's a left issue, and then next day, it could be beating to the left, but it's still left, or I guess it could be the opposite, right?
Yes, but as long as each day you see it
Just right.
in center, right, and left gaze, it's all going to the same direction.
Ah,
It's all going to the right one day in all three positions. The next day it switches, it's all going to the left. All three
Okay.
positions going to
Okay.
the left. Then you're like, okay, it's unilaterally fixed nystagmus. It's going to one side. That makes me feel better. Now, I would think in a hyperacute state, you'd say you'd have, let's take this patient who has right beating, and a positive left rapid head thrust. The next day, if the nystagmus switches sides, I don't think the rapid head thrust is gonna switch sides. I think it's, the rapid head thrust is probably the same each day, but the nystagmus can switch. So this would be the classic nice picture, and you know exactly what's going on. This is the concrete. I feel good about this. I'm excited to get this patient into outpatient. PT is very helpful, especially when started early for these patients. Now, if this patient, the doctor says do the Epley on this dizzy patient, would you test the Dix-Hall pike? You've seen all this. This is your objective findings. The subjective fits, okay, it's a constant dizziness. Does get worse every time I move my head, but it's always there. I always have this dizziness. It's not just positional. It worsens with head movement, but it's constant. Would you do a Dix-Hall pike? I would not. It will make the patient more nauseous. You'll see exaggerated nystagmus for sure. If you're curious and you think the patient has low irritability and they can tolerate it and you just want to mess with them and see what happens, go ahead.
If you need to practice your test,
You need to practice.
and then the ED nurse will be mad. Like, what did you do?
Yeah. What do you think
Just
the,
hit him with silver.
if you have them stand and put their feet together and close their eyes in a neuritis patient, what would you anticipate them doing? Yeah, fall right over probably. That's not necessarily a central sign. I think there's a lot of people out there that think if you can't do a Romberg, you have a brain tumor or something. But that's not the case. This is, they're not gonna be able to their vestibular spinal reflex is also damaged. So they're not gonna be able to find center very easily. So I've given up testing Romberg in these patients in the emergency department because I'm like, I know what's gonna happen. I'd rather focus on, I've already found what's important. I'm just gonna stick with minimizing now how much I irritate their system and stick with what's really important. For sure, down the road, in outpatient, we talk about, we do the Romberg, and we're gonna get into this today. And their gait, will they be able to walk?
Not well.
Not well, but
Maybe.
not like a stroke patient.
Right.
Yeah.
You are like dragging down the hall and holding up, like probably contact guard, maybe min assist, they could probably walk with a walker, they're stabilizing, they might be leaning to one side. They are not, and you guys have walked with a stroke patient, that's different, okay? All right, so that's the classic neuritis patient, good. So, now, let's say you found all of this in the emergency department. You don't need to go on to do your central neuro exam unless you see a reason why. But if that's the clean picture you've got, you don't have to do your cerebellar testing, your myotonal testing, your DTRs, unless you have any suspicion this is a stroke. You've already shown this is classic vestibular neuritis case. So you can stop what you're doing, get the patient back in bed, and start your education. And you need to talk to the doctor, okay? So here's the education that I'm gonna suggest for you guys. I'm just gonna have you listen to me first, and then we'll go through the slides a little bit. So the number one thing to educate a patient on is, this is a pretty simple inner ear virus that's going to get better. You will do worse if you cocoon in bed all day, and I use the word cocoon all the time with these patients because I think it means a lot to them. I think if you use powerful words, it doesn't have to be cocoon, but do not hibernate in bed. Do not sit in the dark and feel sorry for yourself. You need to be able to actually adapt your brain to this problem. And the whole vestibular world is about adaptation, so I use that word a lot with the patients. No cocooning, you need to adapt your brain. Your brain can compensate for this very well. So the way we start off with this in this acute, miserable state that you're in is frequent bouts of short distance walking. I don't care if it's 2 minutes, 5 minutes, 10 minutes, whatever you can tolerate for a short period of time, and then if your symptoms start to escalate, you go lay down, sit down, take it easy after that. But you can't sit in the dark all day. I want you getting up every hour for at least 5 to 10 minutes. That's one of my classic quotes to these patients. If you can tolerate more walking, progress to a half an hour, but maybe 5 minutes more each day. If you can't, that's fine. Listen to your body, rest when you need, but get up every hour for at least 5 to 10 minutes. Keep the lights on, use your eyes. Try to move, make sure you're safe though. Have your husband next to you, have the walker. You're gonna tell the patient how to be safest based on that patient. So walking safely is a big deal for these patients. Otherwise, I'm telling you, they wouldn't do it and they would lie down all day. Oh, I should probably rest. And they're not gonna adapt as quickly and it's gonna be a little bit more of a chronic problem. Okay, so the number 2 thing to tell patients is there's 3 categories of vestibular rehabilitation, okay? Gaze stabilization is the most important for these patients. So when we say gaze stabilization, that's your VOR exercises, your vestibular ocular reflex exercises. So I'll take you down this road a little bit and then we'll talk about VSR. Does everybody have their folder from last time? Can you take out the B letter? And the packet that's stapled with the vestibular rehabilitation guide. It's pretty straightforward, and I think if you just actually read through it, you're gonna get a lot of good information, intuitive information as experienced PTs about vestibular rehab, but we'll take technical detail of it right now. Okay, so take your B. Everybody stand up, please.
It is B.
Find a space against on the wall and take the B at your eye height. So the actual letters at your eye height, not necessarily the paper, but the B is at your eye height.
Thank you.
Supposed to.
Is this the height we want to be or the height we are?
Way up here.
Why don't you go actually here, because you're gonna need to be in arm's length away. Okay, so this is how, if you can coach a patient even early in their vestibular rehab, this would be the ideal way to start the VOR exercise. Put your thumb against the B. You see how it's about your thumb, the size of the nail of your thumb? So I always say to patients, you can use this target or you can use any other target you care to look at. It's gotta be the size of your thumbnail. That's where most of the evidence is on this exercise. Okay, so you're gonna start with, oh, and the other thing is there should be a closed, fairly complex target. So if it was a letter X, that's open and it moves in your vision easier. So if I always say like draw a yin yang if you get sick of looking at the B, if you're an artist, draw a closed target about the size of your thumbnail. Okay, now stand an arm's length away from the wall. And you're gonna start here. Actually, you guys look at me first. This is how I describe it to the patients, and then you're gonna do it. So let me demonstrate first. So you're gonna start to turn your head left to right like you're shaking your head no, and it's about 30 degrees off center. So it's like collar to collar. It's not this huge range of motion, okay? About 30 degrees off center. You're gonna turn your head continuously, because a lot of patients will like stop, stop, stop. You want it to be constant rotation in good posture. So I always teach that too. You want shoulders back, chin in a little bit. You don't want to be frumpy when you're doing this. It's gonna hurt people's necks because they gotta do this a lot. So good posture, turn your head left to right like you're shaking your head no, continuously. And then I say, good, that's the range of motion you want. Now, you're gonna start slow, and I always say, I want you to keep the target steady. Is it steady or moving? And if it's steady, then you can start to increase the speed until you see it move. So for me, when I go this fast, the target starts to slide all over. This is too fast for my vestibular ocular reflexes to maintain visual stability. So the human inner ear can do about 120 revolutions per minute. That's more like dancers, ballerinas who are constantly spotting. Normal populations is more like 80, 90, 100 for probably all of us. We could probably keep that pace. Unless you have migraines, you tend to not do as well as this. Any sort of ocular vision, if you don't have corrective eyewear, you might not be as fast with it. If you have anxiety, if you have neck pain, those might be inhibiting factors. But in the norms, we're looking for like 80, 90, 100. I don't say that to the patients, but just educating you guys. So you want to have them start slow, and then you go fast till you see it move. Now that's your ceiling. I'm going too fast for my VOR. So now I'm going to slow it down just a little bit, and you play with the speed until you find your fastest speed with keeping it steady. So it's a subjective awareness of, I'm going too fast, now I'm going to slow it down a little, now you keep it steady, 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 that's as fast as you go. If you go any faster, it starts to move. So you want to be constantly pushing the border of it almost moving, but it's not. It's on the border. Okay, so line yourselves up. I'll explain it again how I explain it to patients. Arms length away, good posture. Don't let your chin jut forward, shoulders back a little bit. Now start to turn your head left to right like you're shaking your head no. Just about 30 degrees off center, collar to collar. It's not a big motion. Start slow. Is the bee moving or steady? Good. Good. Now pick up the speed. Don't change the range. Pick up the speed until you see it actually start to move.